and 26.3% were outsourced. That was quite a significant increase on year 7, where there was only 19.1% that were being outsourced. So there's a clear indication that outsourcing is certainly here to stay and probably on the increase. Assessment of mortality remains good, and we've been quite consistent over year 7 and year 8. However, timeliness to theatre is where we've really identified that there is significant pressure. In previous reports, we've looked at time to theatre from time of decision to operate, and we've always felt that that possibly sheds light onto the timeliness of the pathway in a more favourable way than potentially patients are actually experiencing. So we've decided to look at time of arrival in hospital to time of arrival in theatre for our emergency laparotomy patients. And as a surgeon, I know that not every patient comes through the door and needs an emergency laparotomy immediately, and there are groups of patients for whom a period of watchful waiting and conservative management is entirely reasonable, such as patients with adhesion of small bowel obstruction or diverticulitis. So in order to try and remove some of those patients from the patients that we were looking at, we created some surrogate groups to try and group together patients who we felt were likely to need urgent surgery. So pre-op systolic blood pressure that's low, sepsis suspected at time of arrival in hospital, predicted gross peritoneal soiling, and sepsis suspected at time of admission to operate. And what we saw in those groups is that consistently across all the groups, patients were really waiting an excessively long time from arrival in hospital to arrival in theatre. And we felt that patients were experiencing unacceptable delays from when they arrive in hospital to when they arrive in theatre. And when we looked at those groups, but with the sort of frame of time from decision to operate to time of arrival in theatre, we could see that time of arrival in theatre with those markers was considerably shorter. And so there is an extraordinarily long amount of time where patients are waiting for that decision to operate to happen. Anaesthetic input for preoperatively particularly has tailed off year 7 and year 8, and we think that probably is related to COVID and a hangover from the COVID period. High risk patients though do have anaesthetists and surgeons in theatre, and that's pretty consistent, but there has been a drop off in admissions to critical care post-operatively, and again we think that's possibly a hangover of COVID and capacity issues. Elderly care input remains low, but it has improved a little bit in year 8, but that's also an area of concern. And then there are a number of other outputs that are not RAG rated, and in a similar vein to the timeliness of arrival in theatre, timeliness of antibiotic administration has been something that we've been somewhat concerned about. And in the data we found that only 23% of patients with suspected sepsis at admission receive antibiotics within an hour, and 25% of those patients who have suspected sepsis at admission wait in excess of 7 hours for their first antibiotic dose. Unplanned admission to critical care and in-hospital mortality rates have both plateaued over year 7 and year 8. So our real drivers at the moment are to try and improve our time to theatre and the management of infection. And what we've identified from the national data is that patients have this sort of circuitous and prolonged route through the hospital from time of arrival in hospital to decision to operate, but that once decision to operate is made, there seems to be a relatively smooth and timely pathway to theatre. And this is just some AHSN data from one of the AHSNs that I've presented to in the last year. The hospitals are represented by each horizontal bar. And what you can see from this is that the pink area is decision to operate to time of arrival in theatre, and the blue area is arrival in hospital to arrival in theatre. So in terms of proportion of the pathway, there's significantly more time spent from arrival in hospital to decision to operate. And whilst decision to operate to arrival in theatre remains reasonably consistent across organisations, even within an AHSN, the time from arrival to decision to operate varies much more greatly between the hospitals. So it's that variability that we really need to target now to try and improve outcomes for our patients. So thank you for listening to me. I'm now going to hand over to my colleague, Dr. David Saunders, who is an anaesthetist and the NELA anaesthetic lead, who's going to talk you through some of the changes that we're looking to make for the Year 10 dataset and the evidence behind those.
Okay, thank you very much, Lindsay. I'll just set away sharing my screen. Okay, back to sharing. Yeah, thank you, Lindsay, much appreciated. Good afternoon, everybody. So I've got two topics really to talk about just now, and because of reasons of time, these are quite constrained slides. Firstly, I'm going to discuss some quite extensive work that the project team of NELA have undertaken through this winter, 4 or 5 months worth of work, reviewing and updating the clinical standards against which NELA will audit from next month. So this standards review work this has gone on since the inception of the project. It's always been an iterative and evolutionary process, but it's quite timely with a new contract from NELA to review this in a little bit more detail. And that review of the standards, that informs the data set and the questions that will be posed in the revisions to the web platform that are also coming for next month. So it's a good opportunity to introduce you to some of those concepts. Secondly, I'll outline how we think best practice tariff is going to work for next month, because there's been a change in focus. More about that in a moment. Okay, please do ask any questions as we go along. So we've reviewed a whole list of publications made by other bodies, not proposing to talk through all of these, but there's one really important one that I do want to draw to your attention, published by the Royal College of Surgeons 2018, the high-risk general surgical patients. I would strongly recommend, if there's one thing to take from my slides, please do read that guidance. And that single publication has informed lots of the standards that NELA has adopted to audit. Really importantly, this is a change in mindset, I think, that's going to be required, certainly for me as an anaesthetist. We need to think about the categorization of urgency of the patient's care, not just from the point of decision to operate, which traditionally has been when the clock has started for purposes of RAG rating the performance of hospitals within NELA, but instead it's from the time that the patient presents to hospital. So right from the get-go, patients need to be categorised as per the RPS into one of 3 categories. Those requiring immediate management, non-immediate management, and a 3rd category of non-operative management. And importantly, these terms apply to both the diagnostic aspects of the patient's pathway as well as the laparotomy and management pathways. And there's an element of chicken and egg here, because you can't know whether the patient's pathology falls into requiring immediate management until you know what the diagnosis is. So it's going to be important that the default position for an adult patient presenting to hospital with an acute abdomen is that they fall into the immediate category of diagnosis and management until proven that in fact they're in the non-immediate or non-operative pathways. And so examples of the kind of pathology that would be classified as requiring immediate management would be a perforation or infarction to the bowel, uncontrolled hemorrhage, generalized purulent or feculent peritonitis, strangulated or ischemic bowel, tender bowel obstruction at risk of perforation, or systemic sepsis. Those patients that can be managed in a less immediate or non-immediate manner would include those with a non-tender bowel obstruction, or perhaps those with suspected intra-abdominal infection but without systemic sepsis, for example, diverticulitis. A non-operative group, Emeng is going to discuss in a bit more detail shortly, so I won't dwell on that group just now. So from April, that's year 10 of the NELA audit programme, there's a whole list of different topics that we will report against at the end of year 10, and we will RAG rate the performance of hospitals against a number of different metrics. Some of that as we go along, some of that will be in the annual report. But I'm just going to pick out 4 of these just now as examples of the evolution to the standards in the data set. So radiology, this boils down to whether or not a CT scan was done, the timeliness of the request for that CT and the reporting of it, the grade of the reporter, and a new topic there around direct discussions between the reporting radiologist and the requesting team, whether that's the emergency medicine team or surgery. So NELA will RAG rate the proportion of patients who received or should have received immediate surgery who had a CT scan that was reported by a senior radiologist within 1 hour of the scan being undertaken. And secondly, NELA will RAG rate and report the proportion of high-risk emergency laparotomy patients who undergo preoperative CT scanning where there is direct communication between the reporting radiologist and the surgeon, either by telephone or in person. So above and beyond a written CT report. Okay, example 2, risk assessment, preoperative decision making boils down to effectively was a mortality risk assessment done, as we've reported for a number of years. The definitions of what constitutes a high-risk patient, a subtle evolution there. So as previously, a NELA calculated mortality risk score of 5% or greater makes them high risk. Clinical judgment of being high risk labels the patient as high risk. But importantly, if the patient is significantly frail, defined by a clinical frailty scale score of 5 or greater, that will also categorise the patient as being at high risk. Finally, the absence of any form of formal risk assessment categorises the patient as being at high risk. So the kind of RAG-rated metrics that NELA will report include the proportion of patients where a standardised mortality risk scoring tool has been used, and secondly, a sort of composite measure where the proportion of patients in whom a risk assessment was documented both preoperatively and postoperatively. Now, the risk scoring algorithm within the NELA platform is changing, hopefully changing to make it easier. So we've called this a parsimonious risk score. At the moment, there are about 22 variables that go into giving a NELA mortality risk assessment. That is being reduced to just 13, that are on that slide in front of you. Importantly, the last variable that is now informing the risk assessment is the predicted surgical pathology to some extent. So currently sitting in tab 5 of the platform is a big long list of indications for surgery. And that's always sat in a slightly anomalous place in the registry because it's part of the tab 5, which is data collected in theatre once you know what you're dealing with, but it asks a question in hindsight, or at the time of booking the case, what was the indication for surgery? So that's being moved forward now as part of the risk assessment. The same list of options is available, and then behind the scenes, the algorithm categorises that specific indication into one of just 5 STEM categories, if you like: ischemia, sepsis, bleeding, obstruction, or other. And there's a hierarchical nature to these where it looks for one and that might score higher than the next, might score higher than the next. It's difficult to describe in a short space of time, but that will become apparent when you start to use the web tool. We can talk about that in more detail if you'd like to in some Q&A. Okay, third example of standards review and subtle changes to the data set around timeliness of access to theatre. So we've reported on this for a while, but instead of reporting against a self-stated urgency of getting to theatre, we will look retrospectively, because we will know the findings in theatre, and we will report the proportion of patients who received or should have received immediate surgery within 6 hours of arrival in hospital. And secondly, we will report on the proportion of patients where it is recorded that access to theatre was delayed beyond the original intended urgency. Final example around frail and elderly patients, whether or not a frailty assessment was done, and whether or not post-operatively the patient was seen by a member of the hospital's perioperative medicine frailty team. There's a subtle change in wording to date that has always said elderly care. That's been broadened. That definition has not come from NELA, that's come from the Centre for Perioperative Care, CPOC, at the Royal College of Anaesthetists. So NELA will report the proportion of patients aged 65 or older where a formal assessment of frailty was undertaken. And secondly, NELA will report on the proportion of elderly or frail patients who received post-op assessment and management by a member of the hospital's perioperative frailty team who has expertise in comprehensive geriatric assessment. So that's all I'm going to talk about just now around the standards and dataset changes. Just to emphasise, please do look at this publication from the Royal College of Surgeons. It's really important. Okay, moving on. Best practice tariff emergency laparotomy from next month, 23 to 25. So for those in Wales, this does not apply. Emergency laparotomy best practice tariff applies to those hospitals in England. The tariff is set by NHS England. The performance of trusts, not individual hospitals, will be measured by NELA, and payments will be made by commissioners directly to those trusts. There are two parts to the best practice tariff. Both of these standards need to be met to meet the enhanced tariff. So firstly, risk assessment, the proportion of all patients who receive a documented assessment of mortality risk as part of the decision to operate. And the target there is 85% of all NELA patients need to have had that formal assessment of mortality risk preoperatively. Secondly, perioperative frailty team input, the proportion of patients aged 80 or older or 65 and frail who receive input by perioperative teams experienced in the management of older patients. The target there has been set quite low at just 40% for the forthcoming year, but that is likely to increase quite rapidly over subsequent years. So the way this works is that there's a base price and an enhanced best practice tariff price. The base price is set at 90% of the best practice tariff price. There's a precondition for hospitals that want to claim the best practice tariff. So there must be in place agreed multidisciplinary pathways of care, agreed between all key stakeholders: emergency medicine, surgery, anaesthesia, critical care, elderly care, radiology. And those pathways in place must cover as a minimum both diagnostic and laparotomy phases of the patient's pathway. The tariff differential is worth, on average, £900 per case, and I'll show you that in a moment. But the number of patients assessed for whether or not best practice tariff was met, the number of patients where payments are made is not identical to the NELA registry. So the assessment of standards is against the data recorded in NELA, but payments are made for all cases meeting a basket of HRG codes, operative codes, which I'll show you in a moment. But the whole thing does require engagement with NELA, so good case ascertainment within the platform is a precondition of payment of best practice tariff. I'll show you our understanding of how it works, but risk assessment, let's just emphasise this. There needs to be a formal mortality risk assessment, i.e. that is the NELA parsimonious risk score as just described. That needs to be documented in the notes to meet the standard. An assessment of frailty can inform clinical judgments about whether or not the patient is high risk, but a frailty assessment alone is not adequate to say a formal assessment of mortality risk has been done. Number two, perioperative teams experiencing the management of older patients. So this wording has been taken from guidance published by CPOC, and it states that the perioperative team should be multidisciplinary and have expertise in comprehensive geriatric assessment to deliver what's on the screen in front of you, which, as I interpret that, the majority of practitioners that can deliver that standard of care are members of the elderly care community. But I think the way it's been worded, it opens up the option that a perioperative physician with specific training and expertise in comprehensive geriatric assessment could also now meet this standard, rather than it being specifically an elderly care doctor. So BPT, how does it work? Which cases will the trust be paid for? If there's an example trust, blue circle, with 100 NELA cases, they've got good processes for risk assessment. 90% of their patients receive a risk assessment. Half of their patients, which is about average, are elderly and or frail. And of those elderly and or frail patients, 21 of those receive perioperative medicine frailty team input post-operatively. All the standards are met in this hospital. The payments, however, will be made on a subtly different patient group that largely overlaps the NELA registered cases, but defined by HRG codes. So an example here would be a patient who has a hemicolectomy because of appendix pathology is not a NELA eligible case, but the HRG code for that operation is eligible. So it's likely that the payments actually will exceed in number. There'll be a greater number of patients against which payments will be made greater than the NELA registered cases. So in this example, the BPT uplift on average £900 times 105, £94,500. Well, it depends whether you can see that as extra payment, or you can say that is the risk of losing that nearly £100,000 of income if the standards are not met. If case ascertainment is poor, so in this example, there were just 60 NELA cases registered. In fact, there were 100 patients that should have been in the registry. The standards of care in that hospital are good, but the commissioners may well decide not to make payment on all 105 patients because case ascertainment is poor in NELA. If risk assessment is poorly done, so this hospital has a similar number of NELA cases, similar proportion of elderly, frail patients, and good processes of care for post-operative frailty team input, but risk assessment is badly done, the BPT standards would not be made and the money would not be forthcoming. Likewise, in this hospital, they're good at doing risk assessment. They've got 50% of their cases are elderly or frail, but they have inadequate resources for frailty team input. Just 10 patients out of 50 received by the frailty team post-operatively. BPT will not be paid. So how much is it worth? That's the HRG basket of cases with the codes down the left-hand side and the description of those operations in the middle. There's the best practice tariff, the non-best practice tariff, and the potential uplift in, or downlift, depending upon which way you want to look at it, in tariff. So on average, it's about £900 per case on all of those patients operated on the hospital that meet those codes. Importantly, so the same operation in a more comorbid patient, not only is the absolute tariff increased, but the differential increases. So that's an important role for the coders within hospitals, that comorbidities are coded accurately and comprehensively. So that's all I'm going to present. I've talked to you there about some of the changes to standards that NELA will audit against and how they have shaped forthcoming dataset changes. In particular, I've introduced you to this parsimonious risk score, and also talked about this change in wording towards the perioperative medicine frailty team rather than elderly care. And I've reviewed there how we envisage best practice tariff working in England. Thank you very much. I'll hand over to Elaine to talk us through the exciting NELA project.
So just before Enang starts, I just wanted to remind everyone to use the Q&A function. We've had a few questions that have come in so far, but we've had loads and loads of information and lots of new information. So if there's anything that you or your colleagues want to ask any further questions about, stick it in the Q&A, and then when Enang's finished talking, we'll rattle through as much information as we possibly can. Away you go, Enang.
Great. Thank you for instructions. Right. Thank you, Dave. Thank you, Lindsay. And thank you for the opportunity to speak at this webinar today. A very good afternoon, everyone. So I'm going to try my best to give you an outline of this new project, the NELA, that NELA is currently setting up. And we hope to roll this out in April 2024, which is the next financial year. And starting off, I'm going to give you an introduction to the project, moving on to what we have done so far, what we're currently working on, and our next steps. So since 2012 till today, the data that NELA has collected for patients undergoing emergency laparotomy has allowed us to identify areas of clinical priority, and this has led to improvement around perioperative care for patients undergoing emergency laparotomy. However, on the flip side, we have another group of patients, the one highlighted in the red box, and these are patients who require emergency laparotomy, but do not proceed to have one. So this no laparotomy or no lap group of patients remain unexplored, and we have very little knowledge about them. We're not clear how many patients constitute this group, their demographics, their underlying pathophysiology, and what their short and long-term outcomes are. And with so many unknowns about this group of patients, trying to define what treatment options are best for them is quite limited. And it also directly restricts shared decision-making in this critically important group of patients. And some of the examples about these areas that we would like to know more about this group of patients are reasons why they don't have laparotomy. Are they being referred to end-of-life care, and if not, why? Similarities and differences compared to their counterparts who have laparotomy. Now, you probably ask, what is the prevalence of this no-lap group of patients? So from the literature search that we've done so far on various databases, we managed to identify 2 prospective cohort studies looking into this no-lap group of patients that have been published. So locally in the UK, McKelvin and her team has conducted a single-centered prospective cohort study. They tried to characterize this no-lap group of patients, looking at their outcomes compared to their counterparts who received emergency laparotomy. They managed to recruit just over 300 patients, and about a third of these patients did not undergo laparotomy. So their prevalence of no-lap in their study is about 32%. There is also a similar study that was done in Denmark. They managed to enroll 250 patients into their cohort study, and we found just under 10% of patients fulfilling the definition of no-lap. And what is interesting from both studies is that the most prevalent diagnoses among this group of patients are similar. So the top 3 diagnoses are intestinal obstruction, perforation, and intestinal ischemia.